I would like to answer the first question. What is the most critical finding for clinicians in your study? So the most important message is that female sex, especially between ages 30 to 65, is an independent risk factor for more severe, more refractory chronic spontaneous urticaria. And women in this age range have significantly worse disease control, more angioedema, higher quality of life impairment, and more comorbidities. So clinicians should therefore anticipate lower treatment response and a higher disease burden in midlife women. So the second question is, how might hormonal transitions and immune mechanisms interact to worsen disease burden in women aged 51 to 65? So I believe that this P corresponds to the menopausal transition. Indeed, I think more about it, and I would also make a subgroup between ages 40 to 50 and 50 to 65 and compare also patient groups, but now I don't have this opportunity. So I believe that in this period of female reproductive period, estrogen levels decline, that might alter mast cell reactivity, and also this creates a pro-inflammatory milieu. The anti-inflammatory pathways drop, and females have more inflammation in their bodies around perimenopause and menopause. And autoimmune activity rises, including thyroid and systemic autoimmunity. And there are also higher CRP and metabolic changes that also contribute to systemic inflammation in this age group. Together, these hormonal and immune shifts likely amplify mast cell activation and promote a type 2B autoimmune endotype, that is the more severe endotype of CSU, that leads to more severe and treatment refractory chronic spontaneous urticaria. So future studies must be looking at the autoantibodies that are generated against Fc epsilon receptor and also the IgE itself. Maybe compare the autoantibody levels in female patients in these age groups. So it would be very enlightening for us to understand the pathomechanism. So the next question is, does poorer disease control with omalizumab and cyclosporin in women indicate a need for sex-specific treatment strategies? So we don't need different medications, but maybe we may have a different threshold for action. We may act more quickly in females, expecting that their response may be lower compared to male patients. So, because we found that women respond less to standard dose second-generation antihistamines, omalizumab, and cyclosporin treatment, so physicians should be escalating treatment earlier when control is poor, monitor response more closely in women aged 30 to 65 years of age, consider comorbidities, autoimmune, metabolic, and psychiatric, that may blunt treatment effect. So, yes, treatment algorithms should be applied more proactively in female patients, especially during midlife. The next question is, how should comorbidity screening be integrated into routine care? So in the routine care, the International Urticaria Guidelines suggests only to screen for autoimmune thyroid diseases. So screening for other diseases only depends on patients' complaints or symptoms or any findings that may point out to another comorbid condition. So it's not a mandatory screening. However, in our study, we found that female patients, especially between 31 to 65 years of age, have a lot of comorbidities. So from this paper, I would suggest that we screen for, of course, thyroid panel. Basic autoimmune screening can also be suggested, maybe ANA if indicated. For example, if the patients have arthralgia or photosensitivity, we may consider CRP and metabolic parameters, especially after 50 years of age. But CRP is also a routine lab value that is recommended for every chronic spontaneous urticaria patient. Screening for asthma, NSAID intolerance, and gastrointestinal symptoms is also important. And mental health screen is also very important because 1/3 of all CSU patients have psychiatric comorbidities. So it's important to integrate a mental health support for our chronic spontaneous urticaria patients. It's very important. So these are the takeaways and answers to your questions. I hope you find this presentation useful. Thank you very much.